what I want to talk to you today is, in Washington, D.C., we have some good ideas, a lot of bad ones, but this is a good idea, and hopefully I can convince you that it's time to finally end this artificial distinction between housing and health. So what I'm going to cover is, in the time I have with you, is looking at it as a social determinant of health, argue that we've sort of been down this road before, going back 100 to 150 years, looking at the sanitation movement, and then I'll talk about a problem in our framework, which is basically the discrepancy between the shared commons, which is the undergirding principle for most of our environmental and public health laws, and fragmentation. Is housing actually part of the shared commons? I'll talk a little bit about the problem of why health investments are unlike any other health improvement or housing improvement. I'll talk about how to monetize costs and benefits, prevention versus reaction, and then I'll talk about these new WHO guidelines, as well as now that we're in the era of climate change, what resilient housing looks like and healthy housing. And then finally, close with some conclusions about political will, making the case, and the importance of evidence and conclusions. So I'm not going to tell you a fish story here, but this is a salmon, and the salmon is swimming upstream. And that's what we have to do when it comes to housing and health. We need to look at the root causes of what some of our health problems are and understand that housing is a key social determinant of health. So if you go way back, this is the world's first housing law. The penalties were a little severe back then, but basically this is the Code of Hammurabi. And it says if somebody builds a house and his house is not strong enough, the house he has built falls in and kills the householder, that building shall be slain. So I'm not proposing that we do that, but just to show you that housing laws do go way back. Anybody know what miasma is? So it's bad smells, right? This is before we had the germ theory of disease, and the idea was that these bad smells would stalk the neighborhoods of the poor and cause disease and other health problems. We now know a little bit better, but if you ever go to New York City, I encourage you to go to the Tenement Museum. And if you go there, you will see something called a tubercular window. And basically, the way tenements were set up, there were 3 housing units, one on the street side, one in the middle, and then one towards the back alley. The only way they could ventilate the interior one was to put in these interior windows. And it's a little hard to see here, but that's what it looked like. So we've been through this before, and the only reason we really have housing laws at all is for public health reasons. Back in the late 19th century, we had epidemics of tuberculosis, typhoid, and cholera, communicable diseases. And out of that need grew the sanitation movement. And along with better medicine, it created a change in our housing stock, something we all take for granted now, which is what? We installed indoor plumbing. And that was a key component of the sanitation movement, and it helped conquer these 3 diseases. When we don't have that, in some of the parts of the developing world, even today, we've seen cholera outbreaks and the like. So the lessons for public health officials, housing, and architects and planners is that we need to have a housing component to what we do. And then, so indoor plumbing was, it says here it's going to be big, and it was, but it was enough of its own. So the housing codes that we have today basically had their origins in the sanitation movement. It started in England around the 1830s. Jacob Riss published an important book, How the Other Half Lives, which sort of documented the housing conditions that the poor lived in and why they had higher disease rates. So again, housing laws really had their origins in public health needs, and then those 2 groups sort of split, if you will. The public health, the medical profession became more treatment-oriented. In other words, we'll help you, but only after you get sick. And the housing people became more financial and maybe architecturally driven, and they lost the thing that where they were joined at the hip with the sanitation movement. And in my country, it really wasn't until the 70s and the 80s, with the appearance of lead poisoning, where we had an unhappy situation where physicians were trying to develop housing abatement specs, basically rehabilitation specs, and we had rehab guys trying to interpret blood lead data. So you really had to have health and housing working together. that key lesson from the sanitation movement is something that we need to rejuvenate today. Florence Nightingale observed, y'all know Florence Nightingale, right? Yeah, okay. We take credit for her, but the connection between health and the dwelling is one of the most important that exists. So this is a picture of the Cuyahoga River in my hometown of Cleveland, Ohio, in the States. Back in the 50s, this river caught fire, not once, not twice, but several times. So the public saw pictures like this and reacted in fury and said, we drink that water and we breathe the same air. We want something done about that. So we passed the Clean Air and the Clean Water Act and other laws because this was perceived to be part of our shared commons. So the question is housing actually part of the shared commons? Well, this is one definition of what the commons is. It's everywhere, the air we breathe, words we speak, traditions we respect, tangible and intangible, ancient, modern, local, and global. But the kicker is the last sentence. It's everything that is not privately or state-owned. Well, housing is mostly privately owned, and that which is not is also state-owned. So that means housing is not part of the shared commons. And the way we regulate housing has become fragmented over the years. So if you consider, if I'm getting an appendectomy done here in Sydney, I hope it gets done the same way here as it might be in Chicago, right? So because there are common procedures. When it comes to housing, every local jurisdiction has their own codes. And so it's fragmented. It's unlike the sort of common things we would suspect. And so overcoming this problem has financial implications. So a healthy home improvement, whether it's asthma mitigation, mold remediation, or lead remediation, it's unlike any other healthy home or housing improvement. So if you put a new roof on your home or a new furnace in it, when the valuator, is that what you call it here? When they come in to determine how much that house is going to be on the market, they'll factor in the price of the new roof and the new furnace, for example. But when it comes to a health investment, they don't quite know how to do that. And frankly, this is a criticism of those of us in public health. We haven't given them the tools to monetize what that health investment means. So we need to find market vehicles to promote incentives, to provide incentives to promote that sort of investment in housing. Otherwise, we're going to be left with just doing subsidy or enforcement. And so getting the pricing right in housing is important. Otherwise, we're going to be stuck just articulating what the cost is of unhealthy housing. So this is sort of a framework problem that we need to wrestle with. This is sort of the bad news. The good news is we are starting to see, call them labels. Some of you know about green housing systems. Many of them have health components to them. And so now you'll have, if a house meets a certain green standard, that will have a health aspect to it. If it doesn't, then that can help monetize what the investment has to be to bring the house up to a healthful status so it can support the health of its residents. This is sort of one way to think about social determinants of healthy homes. You see there are sort of three factors here: physical and environmental factors, people and behaviors, and partnerships for green, affordable, accessible housing. So, and then you see some of the components at the sideline. So the question is, what exactly is a healthy home? There's also been a lot of work done on social determinants of health in general, and if you look in the lower right-hand corner, housing is there. So it's one of many factors, but it's a key factor that's often ignored, especially in looking at social determinants of health. Megan Sandell, who's a colleague of mine at Boston Medical Center, if you're a medical practitioner, you have doctors in the audience maybe, she thinks that housing is a vaccine. It basically provides the basic kind of resilience that we need to promote good health. So I think that's kind of a clever way to think about it. So these are the key healthy homes principles that we use in the States. And some food for thought. There are things missing here, some things that should not be done. But basically, a healthy home means one that doesn't have excessive moisture and the mold that comes with it. It has cleanable surfaces. It is properly ventilated, meaning it brings in fresh air. Do you know what our ventilation standards are based on in housing? This goes way back, but it's basically used to control body odor. We could do a little better than that, don't you think? We want to make sure the houses are pest-free, so we use integrated pest management, not just have the bug man come in every month and spray pesticide. We want them to be free of injury hazards and also accessible. We want them to be free of contaminants like lead and other radon and the like. Radon, by the way, is the second leading cause of lung cancer, but it's almost entirely a housing-related disease, isn't it? Properly maintained. It has to be affordable. If people can't afford the units that they live in, then they won't be able to properly finance them. The second leading cause of mortgage defaults in my country is because someone has a high medical bill that they can't pay. So the high cost of housing and the high cost of healthcare go together. They're part of the same problem. And then finally, in this era of climate change, houses have to be properly thermally controlled. What exactly does that mean? What are the standards that we're going to use to make a building tight enough, but also healthful? I'm old enough to remember the 1970s when we had sort of the first energy shock. And what we did was tighten up building envelopes so that they couldn't breathe anymore. The air supply became less, they became more moist, and as one guy said, we ended up growing mushrooms in people's basements. That was a bad idea. So this business of how to integrate healthy homes principles into weatherization and energy efficient homes is also pretty important. Now this is a little busy, but healthy homes is a holistic intervention. Now that's a mouthful. I said that to a senator one time and she said, come back when you speak English. But basically, let's examine one thing. Let's look at water leaks. That's the one in the middle. If you control your moisture, you'll deal with simultaneously with damp and mold growth, electrical hazards. It turns out that premature paint failure is principally from moisture, structural collapse from rot of structural members. So you control all those things. And then you control these multiple diseases as well, asthma and allergies, burns and electrical shock, physical injuries, and the like. So it's an integrated package, and inevitably, this is an academic gathering, so in a research component, we want to pick one of those things out and see if we can figure out what the causal pathway is. But fundamentally, Healthy Homes is about a package. It's not just a single intervention, it's a suite of interventions that, when taken together, I think the evidence pretty clearly shows that they work. So these, I'll briefly review the WHO Healthy Housing Guidelines, but basically this is about translating the research. We did this extensive lit review and so forth to build the evidence base to make sure that the recommendations that we were making are actually based on the evidence. And that's increasingly a hard thing to do, but maybe I'm old school, but the facts still matter, right? And so we have to keep insisting that pay attention to the facts, but it's more than the facts. So this document will basically distill a lot of the research that's been done so that we can translate it into changing the way in which we do housing. So this is the infographic. I won't have time to really go through this in detail. I just want you to know that it exists. But there's lots of opportunities having to do with indoor temperature, insulation, accessibility, injury control, toxic materials. This book has a new chapter on crowding, which is increasingly important in many parts of the world, especially in slum housing, and of course indoor air pollution as well. So this is a global problem. Just looking at the injuries, did you know that 1/3 of all injuries actually occur in the home environment? Half of all unintentional injury deaths were also in the home. In Europe, 110,000 people actually die every year from home injuries, and another 32 million require hospital admission, a huge burden on our healthcare system. There are 7,500 deaths and 200,000 disability-adjusted life years just due to the lack of window guards and missing or inoperable smoke detectors. About 10% of hospital admissions per year are due to household crowding and the associated diseases in New Zealand. In India, we had a doctor from India, and she said, you know, I understand the importance of fire and some of the chronic diseases you're talking about. We're worried about buildings collapsing. That's our primary thing. So making sure structural integrity is part of it. Again, in Kyrgyzstan, Crowding causes 13 deaths per 100,000 from tuberculosis. That's annually, every year, kind of astonishing. And then a new figure is that from worldwide exposure to lead, often for lead, we've mainly looked at neurological outcomes, but this is principally from cardiac arrest and hypertension, which is often not recognized for lead. But anyway, 850,000 deaths annually per year from lead, something we think we have controlled. 3.8 million deaths are due to household air pollution from solid fuels, that is using charcoal without ventilation. I once taught a healthy homes course to a group of Navajo Indians, and this guy came up to me at the end and said, you know, what you're saying is nothing new. If you have a fire in your home, we know you have to have a hole in your roof. You have to get the home out. But yet we have gas stoves in our homes, and in many ways, they're not often ventilated properly. So this solid fuel use causes pneumonia and other respiratory conditions. And about 15% of new childhood asthma in Europe is due to indoor dampness. So that amounts to 103 deaths every year. Increasingly, we're seeing more people live in slum housing. That's the preferred term that WHO uses. We all know that migrants and refugees and internally displaced people are on the rise, which also leads to crowding. 1 billion migrants today, and then international migrants and the like. So this is something we need to think through as we plan for our housing supply. How are we going to meet this need as people move around? So we review the evidence. We know that structural deficiencies lead to slips and falls. Poor accessibility for disabled and elderly people leads to injury, stress, and isolation. And there's an important mental health component to healthy housing as well as physical health. Insecure or non-affordable housing increases stress because people have to think about what they're going to spend their money on. If they pay, do I buy my medicine or do I pay my rent? Poorly insulated homes leads to respiratory and cardiovascular problems. High indoor temperatures lead to premature mortality from cardiovascular problems. Indoor air pollution leads to various diseases, respiratory and cardiovascular problems, increases in allergies, and irritant reactions. Over the last 20 years, the prevalence of asthma has doubled. And no one fully understands why that is. But one theory is we're in our houses more than we used to be. We have more carpet. Houses tend to be moister environments. So there may be a key component of this asthma increase that has to do with housing quality. And I think the other stuff we've already mentioned. So these are the key recommendations in the WHO guidelines we made. And Peter and I can talk to you over a beer about how difficult it is to make a strong recommendation from WHO. But basically, the strong recommendations had to do with reducing crowding, dealing with indoor cold and properly ventilating homes. A lot of that research has actually been done in New Zealand to great effect. In climate zones with a cold season, having efficient and safe thermal insulation being installed in new housing. That was a conditional recommendation based on the particular climate in the home. Same thing with indoor heat. When it comes to home injury and safety injuries, we said that homes should be equipped with safety devices such as smoke and carbon monoxide alarms, stair gates, and window guards to prevent falls. And also accessibility also emerged as a strong recommendation based on the current and projected prevalence of populations with functional impairments being on the increase. And also many of us, like me, we're all getting older. And that means accessible housing has to be a key component. All these interventions have important co-benefits. So if we improve thermal insulation, weatherization and ventilation, and we make it energy efficient, we can improve indoor temperatures that support health. Philippa Howden-Chapman in New Zealand conducted a study where they insulated bedrooms and the average temperature went up, I think, 0.5 degrees centigrade. And I said, well, boy, that's not very much. And yet the health consequences of that were profound. They were huge. So properly insulating homes is important, and it also has this important co-benefit on reducing carbon emissions and reducing energy costs. Reducing crowding also contributes to educational outcomes. because children are able to study more effectively. If you have a disruptive or unhealthy home environment, they're not going to be able to focus the way they should. Improving thermal comfort through installation and heating reduces days off of school and work, and improving housing can also create jobs. Some of our studies in the US, we've looked specifically at how many jobs, if we do an intervention, like if we replace windows for lead hazard control, how many jobs will that create in both manufacturing plants that make windows and people who installed them? I'm not going to go through all these, but again, this is a randomized controlled trial in housing. These are the various home injury interventions that were done as a package, not one by one. So it's not as though you get a better health benefit from smoke alarms versus, grab bars. It's an integrated whole. In Australia, you've done some studies here looking at damp housing, gas stoves, and the burden of asthma. And the key findings from that report were about a fourth of Australian homes have dampness problems. 38% of them have gas stoves. Nearly 8% of childhood asthma in Australia is attributable to damp housing, and 12.3% of asthma is related to unvented gas stoves. Gas stoves give off nitrogen dioxide, a key respiratory irritant, as well as carbon monoxide and other products of combustion. And I tried to convince my wife to remove her gas stove, and she said, "You'll get rid of my gas stove when my cold, dead fingers are pried off of it." She loves her gas stove. So the challenge is to ventilate it properly. What are the ventilation standards we need to put into place? But the conclusion, if we did the proper exhaust ventilation, the burden of the disease would be reduced from 12% to only 3.5%, a big improvement. So the conclusion is that exposure to damp housing and unvented gas stove, it's a problem here in Australia, and it's associated with the childhood asthma problem. So we can either pay to treat kids in the hospital, or we can fix the problem at the beginning. At the end of the day, it makes no sense to treat a child's asthma symptoms with steroids in the emergency room. We control the symptoms only to release him back into the home with mold or other asthma triggers, where he ends up getting re-exposed, having another asthma attack, and then ending up right back in the ER. It goes round and round and round, and it's short-sighted. In the US, we know that racial disparities and ethnicity disparities are important. This shows the prevalence of housing with severe and moderate deficiencies. So for non-Hispanic blacks, it's 3.2% have severe deficiencies, 2.5% among Hispanics, and then 1.5% for whites. So these, when we do healthy housing interventions, we also have to pay attention to the population and recognize that housing deficiencies are more important among certain disadvantaged groups, both by income as well as race and ethnicity. This is HUD. This is the office I used to direct. Its key attribute was it had the longest acronym in the department. So it stands for the Office of Lead Hazard Control and Healthy Homes. But basically, the mission there is to help all Americans, but especially children, living in low-income households reach their full potential by making homes safe and healthy. The vision is to lead the nation to a future where homes are both affordable, and then this is the definition of homes: designed, constructed, rehabilitated, and maintained in a manner that supports the health and safety of occupants. There's actually one missing here, which is what? Anybody take a guess? Demolition. Houses eventually are demolished. They also have to be demolished in a safe way so that the dust isn't spread all over the place. So the goals are, to develop a national framework to end some of these cost efficiencies I discussed earlier about properly pricing homes, doing the research so that we understand what works and what doesn't work, and then find ways to mainstream the healthy housing approach so that it's not just this research finding, but it actually drives the way in which we end this stupid shifting of costs from inadequately maintained housing to our medical care sector, and then enabling communities to find ways to create and sustain those healthy homes. So in 2009, the Surgeon General issued a call to action, and in my country, that's a big deal. That's how the whole tobacco thing got started. The Surgeon General issued a call to action. So he did one for healthy homes, and this was, again, the definition cited. It has to be put in a location that's healthful. It has to be designed properly. It has to be properly built. by the trained construction workers, renovated, and then also maintained in ways that support the health of residents. So what are we doing now? We allow building materials to come into our housing stock that may be a bad idea. It was a bad idea to put lead in paint. It was a bad idea to invent vinyl wallpaper. Somebody thought it looked nice, but vinyl wallpaper doesn't allow walls to breathe. It traps moisture and it causes mold. We had Chinese drywall come in that had stuff. So it would be better, wouldn't it, to test building materials before they're used on the market so that we don't have, as epidemiologists, we don't then have to track the disease outcomes of allowing toxic materials into our building supply. Anyway, we released a National Healthy Housing Standard several years ago with two HUD secretaries. Basically, this is a model code that uses the current evidence on what specific characteristics in houses written as a code that code inspectors could enforce in a way that makes sense and is practical. We also calculated what the environmental burden of disease that was associated with inadequate housing. This was done mainly using a European database. It hasn't been done in the US and needs to probably be done here in Australia. But basically what we did was look at a wide variety of factors, and then we estimated the population attributable fraction from relative risks from the scientific literature, and then we estimated how many premature deaths and disability-adjusted life years. So you see for injury factors, lack of window guards, lack of smoke detectors cause 10 deaths per year in the European region and 7,500 deaths in the European region. Same thing for mold and dampness and other factors. So putting numbers on it is helpful because it helps underscore the magnitude of the problem. So from a research perspective, what we do as researchers is we tend to emphasize what we don't know, right? Because that's our next research project. We want to focus on that. But policymakers, they want to act on what we know. And so there's often this disconnect about translating research findings into political action that decision makers can do. So finding ways to bridge that research policy gap is pretty important. So I think you do that by quantifying the magnitude of the problem, document the solutions, figure out what the costs are going to be, and then find a champion in your legislature to carry the ball. And that has to be done not just with data, but also through storytelling. We talked about that today. But I would testify before our Congress about the extent of a particular health problem in housing, but I would always take a mom with me who would get up to say to members of Congress, I didn't need the health department to come out to my house after my child got sick and tell him to feed him right and wash his hands. I needed help getting my house fixed. And when she told that story, it just, it gripped decision makers. So you got to put a human face on it. They say behind every statistic is a tear, right? So we need to find ways to make those tears real. There are some things we don't need to research. This was an article published in the British Medical Journal. And so I ask you, which one of you would like to be in the control group for this study? You're the ones that don't get the parachute, right? So some things probably don't need to be researched to death. It's a hilarious article. You ought to take a good look at it. Anyway, this is another study we did. We have cool acronyms for some of these. So this is the MIGHTY study. It stands for Moving into Green Healthy Housing, the Yield in Health. And this was a group of public housing residents in Chicago in 3 developments. They moved out of this dilapidated, horrible public housing into new green, affordable housing. And we looked at some of the health outcomes. These were self-reported physical and mental health. We saw statistically significant improvements in hay fever, headaches, sinusitis, angina, respiratory allergy, asthma severity, and we saw improvements in lost school work days, disturbed sleep, and prevalence of symptoms. And we also saw significant mental health improvements where we measured sadness, nervousness, restlessness, and child behavior. We've also taken a look at how health can be integrated into energy conservation work. So 20% of our weatherization budget from our Department of Energy now goes to do healthy homes improvements. So usually they put in better insulation, they do some air sealing and the like, but while they're there, why not fix the smoke alarm? if it's not working. You're already in the house, and that can be done fairly cheaply. There are a number of studies that have shown the same thing from these new green building standards. I Googled it a while back. There are 80 different green building standards out there. Most of them have health components to them, but not all. But these are some of the studies that show how health improvements occur as a result of implementation of certain green building standards and energy conservation practices. So I'm not going to march through all this, but just to show that there is a significant body of literature out there that's important. Okay, in the interest. So basically, the healthy housing movement is about reestablishing this collaboration between the built environment and health. And there's probably lots of different professionals, but we can think about, developers, builders, public and environmental health professionals, housing professionals, banks, and financial institutions. Most houses are bought with a mortgage, so the banks are involved. They have underwriting standards. Why not have those underwriting standards include certain health components? Government obviously plays a role, as do rehab professionals, and there's lots of others. So I'm not going to march through all these, but it's clearly a multidisciplinary effort, and it's about rebuilding that bridge that works so effectively in the sanitation movement so that we have true collaboration with people that don't usually talk to each other. In fact, housing and health have different languages, and so it's important to bridge that divide. This is Jim Krieger's work out of Seattle. These were the Breathe Easy homes. These were public housing units that were targeted to asthmatic children. And basically, he showed that out of every 2-week period, he had about 5 days that were symptom-free days. He reduced visits to the emergency room in hospitals by 41%. Do you know how expensive an emergency room visit is? So this was a huge benefit. Asthma triggers this is basically allergens and settled dust. It fell dramatically. There wasn't much improvement in caretaker quality of life, but again, showing that if you target housing with specific health improvements, it can have a dramatic effect on improvements. We've also estimated costs and benefits. So this is a Healthy Neighborhoods program out of New York State, and we basically showed that for every home visit, you have a cost-benefit ratio so in other words, for every dollar you invest, you get back $3.50 in benefits, or a net benefit of about $781 per asthma-related home visit. That's a pretty significant return on investment. That's how economists think about this. We should make that pitch about how if we make the investment, we'll get a return on it. The key question is, who gets the benefit? So that's the disconnect. If you're a builder, you're not going to, or a property owner, you don't get that financial benefit, do you? It goes to society. So finding a way to bridge that gap is particularly important. So I'm going to tell this brief story of how did healthy homes begin. So I was testifying before Congressman Carl Stokes, here from Cleveland again, who basically said to me, we have 20 infants who died in Cleveland, we think from mold exposure. What is HUD doing about mold? And I said, I was younger then, so I was able to say something more stupid, which was, well, we have statutory authority to deal only with lead, not to do mold. And he said, well, that's wrong. I'm going to make sure that $10 million goes to HUD to do something about mold exposures. Now, the fellow on the left is Dr. Dor Dearborn. He did autopsies on these children who died. And he said, there are lesions in the lungs that are not consistent with what they had been diagnosed with, which was sudden infant death syndrome, SIDS. So he said, there's something else going on here. And then Terry Allen, the guy on the right, was the health commissioner in Cleveland. And so they decided to let's go out and look at the houses, and this is what they found. This was the furnace, and basically the air supply is over here on the right. And so there had been a flood in this part of Cleveland, and growing on the floor here was this sort of black, they're called black toxic mold, Stachybotrys atra. So this fix was pretty simple, right? You clean up the mold, but you also make sure that the ventilation system is drawing from either the living space or from the outdoor so that you have a clean air supply and you're not using basement air as supply air. So Dr. Dearborn said, every resident that comes through the Case Western medical program is going to spend 1 quarter going out with a housing inspector so that they understand for certain patients who present with respiratory conditions, they understand there might be a housing component that should probably be part of the patient's medical care. Okay, so this is a report we released recently from Pew Charitable Trust to prevent and respond to childhood lead exposure. It did cost-benefit analysis for 10 policies on what lead exposure, how it could be reduced. Are you all familiar with the story of Flint recently? Yeah, some of you are. This was, maybe not. So this was basically a problem in the water system. To save dollars, the emergency manager of the city of Flint decided to switch the water supply from Lake Huron, which is part of the Great Lakes, as a clean water supply, and he switched it to the Flint River, but without adding corrosion control. So all the lead pipes in the city basically became demineralized, so to speak, and they didn't adjust the pH properly. So there was a significant lead exposure. Reuters followed up by showing that actually lead exposures were much worse in thousands of locales than they were in Flint. So this focused the nation's attention on lead once again after about 20 years. So basically, as I said earlier, facts are stubborn things. They're not just alternative reality, despite what our president might say. But the point of this slide is that it's the Enlightenment and the scientific research that we now maybe take for granted too much. It's actually a fairly new thing, isn't it? The Enlightenment's only 400 years old, and it's under attack right now. So we have to make sure that the science still matters, that the actions we take are based on what the science tells us. And that's important for healthy homes. What does the science tell us we should do? And then let's put our heads together and figure out the right way to do it. But I continue to hopefully not naively believe that the science really does matter, that it's important for us to do the scientific process so that we understand what works and what doesn't. So we also operate a political arm known as the National Safe and Healthy Housing Coalition. This is about 400 groups in the United States that basically educates our members of Congress and their local decision makers on why it's important to take action and properly fund healthy housing programs that work. And so this has been particularly effective. I'll tell you a brief story of why it was important. A few years ago, somebody on a senator's staff said, you know, I have these 2 programs within the Centers for Disease Control, one on asthma and one on lead poisoning. Let's take the lead money and give it to the asthma program. Now, I don't know why you can't do both, but they basically did that, and they got away with it because nobody complained from the healthy homes world why that was particularly important. So having a coalition do the advocacy that makes sense and educate members is particularly important. I don't know what your Congress or your legislators are like here, but in my country we say they're an inch deep and a mile wide. So they have to cover a lot of issues, but they rely on people who have the knowledge and the facts and the know-how and the practicality to basically implement some of these changes. Strategic planning is particularly important. This is a 10-year plan that we put together. We basically said, this is how many children are poisoned from lead. If we do nothing over a 10-year period from 2000 to 2010, you'll see some decline. Why? Because houses are demolished. So you'll see some decline, even if we don't take an intervention. If we do regulation, then we can take a bite out of it. But there's still this large gap at the end of 2010, and that we propose basically by doing grants as well as leverage funds from the private sector, we could eliminate that gap. So this plan, which was adopted by the president's task force in the year 2000 under President Clinton, played a large role in dramatically boosting HUD funding. Now, that's the good news. The bad news was they didn't fund it fully. So that's why we're still talking about it. That's why we still have Flint going on. It was funded, but not adequately. So these strategic planning exercises are particularly important, especially when we try to apply the lessons that we've learned from a particular experience to other housing-related diseases and injuries. Healthy housing, basically, we have limitations in both the medical world and the housing professions. In the medical world, we've sadly ended up doing less on prevention and treating people only after they get sick and end up in the emergency room. In the housing system, we basically rely, unfortunately in many cases, for conditions to get so bad that somebody finally complains, and then maybe a code inspector or someone else comes out and takes a look and maybe orders the corrective actions. Both of those approaches are not proactive, they're reactive. And they're more expensive when they're reactive because we've already done the harm. So it makes much more sense to be proactive and implement the changes as a primary prevention measure, not just only acting after the fact. This is unethical. Why should we use our children as lead detectors? Or why do we have to wait for someone to get sick to identify a mold problem? There are inspection protocols. There are instruments that we have that can detect those problems. We should use them and not just wait for people to get sick to identify a problem. So the challenges in healthy housing, I would suggest, are twofold. One is when I first pitched healthy homes to one of our senators who had been on our side most of the time, she said, "This is wrong. I don't want a snappy slogan. I want programs that actually help people." So she didn't understand what healthy homes meant. So with something like lead or asthma mitigation or mold remediation, it's kind of obvious because you have a specific thing. But when you have a healthy homes intervention that has multiple benefits from a single housing systems intervention, that's a mouthful, right? And so finding a way to keep the breadth of the healthy homes holistic intervention package real, but making it crystal clear enough, crystallizing it so that people can make sense, is a challenge. So it's sort of balancing focus with breadth. And then the other challenge is to try and find ways to get the housing market to function properly. That is, to have housing prices properly reflect its actual condition and its actual health status. And that we still have a ways to go on both of these things. So that's why I submit to you that the time has finally come to move this away from just being a good idea into implementation and practice, to have demonstrations, to learn some lessons, to apply it to the Australian situation. You've had two wonderful workshops today with both academics as well as people on the ground who are actually providing housing and developing it and so forth. You need to have both the practical side, the financial side to do it. But it can be done. We've moved the needle. In the States, as you know, you know that our two biggest risk factors, we just dug our way out of a huge mortgage crisis, and we're still reforming our healthcare system at huge cost. And the two are linked. But the reality is that we have very few programs that look at how those two huge financial woe systems are actually linked together. And if we're smart about it, we can drive down the cost of both so that it makes sense. Okay, so basically, housing and health crises, these are flip sides, I think, of the same coin. We have need to do some healthcare reform, and we also need to drive down the cost of housing and make it affordable. Globally, we're going to see an increase in slum housing. We need to do new construction. We need to make sure, by the way, that the workers building those houses are also properly protected or remediating them. We're in the era of climate change, so our housing has to be resilient. We had a National Academy of Sciences report that looked at what should a healthy home look like in the era of climate change. If you're doing disaster recovery, how do you make sure that the homes that you're providing on a temporary or permanent basis are actually healthy homes? How many of you know what a Katrina cough is? This was named after Hurricane Katrina. And after it hit New Orleans, they put down a bunch of trailers and mobile homes that were loaded with formaldehyde. People got sick in them and developed allergic reactions and the like. So that was a bad example of the kind of housing that we need to provide in a disaster context. So that's going to be an increasingly important area of both research and practice. You know, how do we get new houses? You know, after disasters, people want to say, I want it back the way it was, as fast as possible. Well, maybe the way it wasn't so great in the first place. and a disaster, if there's an opportunity there, it's to rebuild in a way that makes sense to promote health and to make sure that over the long term, it's sustainable. So, to conclude, Johann Goethe made this observation. It's not just enough to know, we have to apply what we know. Willing also isn't enough, we actually have to do something about it. So the time has come to implement healthy housing on the nation's agenda. This is Uncle Sam in my country. He says, we want you for this conversation. Ultimately, people are upset in my country with Congress and with the administration for a variety of reasons. But last time I looked, it's still a democracy. So we can figure this out. It has solutions, but it's up to citizens to basically put our heads together and say, this is what we need. Makes sense. It's stupid to pay extra money to hospitals to make people well when we could prevent the illness in the first place. And you do that by investing in part in better housing. So we can figure it out. Did you have marches for science in Australia? So I never thought I'd live to be old enough to participate in something like this, where I was in the streets with thousands of other people chanting, what do you want? What do you want? Peer review. I mean, how lame is that? But peer review is under attack, don't get me wrong. So at this march, I met this little boy, and you can't read his sign, but I had a nice little chat with this 10-year-old boy, and he said, the sign says, think like a proton, be positive. And that's exactly right. That's what we need to be about. So I showed you this slide earlier. This is the Cuyahoga River in 1960. This is what it looks like today. So we can actually correct these problems if we put our heads together, demand certain changes, and make it possible and viable for our political leaders to do what we want them to do. So that's what I've got for you today. I've enjoyed my visit, and I hope that we'll have some great conversations.
Excellent.